Yes, Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everyone. For the people from Middle East, good morning for the people in the West, and good evening also for the people in the East. It's my honor to be speaking today. My name is Suhail Abdullah Rukin. I'm a neurologist from Dubai and a stroke specialist. Welcome to the 62nd edition of MENASO Academy, Cerebrovascular Grand Round, and the second webinar of this year, 2026, focusing on advance in stroke prevention, primary and secondary, held in collaboration with the AHA-ASA. This session will highlight the latest innovation and evidence shaping the future of stroke prevention and care. We are privileging to bring together this distinguished group of speakers to deliver this program featuring the state of arts in the research, expert insights, and dynamic discussion. Through this collaboration and shared experience, we'll strive to advance standard of care in the stroke field. It's very interesting that these type of webinars reaching the 62 edition, which means that there's a good demand, and we are looking to enhance the stroke care across Middle East, Arab world, and globally. I'm so proud the number of the attendees which is attending this type of program monthly, always exceeding our expectation. And I'm sure that having the AHA to be partner with us in this webinar, it will bring more people attention to this type of academy. I would like also to welcome my co-moderator for this session, Dr. Nuran Tahir. Welcome, Dr. Nuran.
Thank you, Dr. Suhail. Assalamu alaikum. How are you? I hope you are doing well. And good evening, good morning, good afternoon for everyone, wherever you are. Today, inshallah, we will be discussing and having a very interesting topic. Dr. Salama and Dr. Muhammad will be presenting two interesting cases, and this will be followed by Dr. Aaron, who's going to present about cryptogenic stroke, what's new and what's the workup. Then Prof. Cheryl will be presenting about primary stroke prevention from guideline to clinical practice. And finally, Prof. Hani will be discussing comprehensive cardiac evaluation in a stroke patient. These are a highly relevant topic, and I'm sure that it will be quite informative and insightful for all of you. Keep in your mind that the questions and answers will be left to the after the last presentation. So, Prof. Suhail, the mic is yours.
Thank you again. I'm seeing on the screen here Dr. Hani Sabur. Assalamu alaikum, Dr. Hani. Good evening. I'm seeing Dr. Aaron. Hi there. Dr. Aaron, thanks for joining us. I'm seeing also Dr. Muhammad Asiri and Dr. Salama. Welcome all of you. Tahiyyati. So let us to start. I would like to welcome Dr. Salama to present her challenge case. Salama is a specialist in the Department of Neurology. She did her neurology program and got her Saudi board in neurology. Also, she's doing currently her stroke and cerebrovascular disease fellowship program at Rashid Hospital, and she's going to present a challenge case which will carry a lot of meaning that we don't see it every day. And she gave the title of this topic, When Minutes Matter for Two. Welcome, Dr. Salama.
Thank you, Dr. Suhail. So I would like to start sharing my presentation, but it says that someone else is sharing. So let me see. Okay, perfect. It's working out now. Okay, so thank you for the introduction, Dr. Suhail. Thank you, everyone. And I would like to start with my case presentation. So what I have here is a 29 years old female. She was previously healthy. She was 10 weeks pregnant, and she was in the mall in a regular day, and she suddenly developed left-sided facial, upper and lower limb weakness. That's when she presented to the hospital, reaching around 45 minutes from symptoms onset. Her NIH score was initially 5, however, it increased to 12. Now, code stroke CT angio was activated. Here we can see a plain CT brain axial view. We will start appreciating that there is some subtle hypodensities along the pericentral gyri, additionally as well in the insular cortex. So an aspect of 7 to 8 was given for her. Moving to the CT angio, we can start visualizing the vertebral artery, common carotid, they're all patent. Additionally, the internal carotid was patent. However, as we are going upward, we will notice that this patient, so we'll notice that this patient has a right MCA occlusion, which can be appreciated more here, maybe. So at this level. So in summary, we have a pregnant female within window. Her NIH is 12 and with a large vessel occlusion. So the question is what to do next. And before I answer what we actually did, I thought let's review the literature and see if we actually align with the guidelines or not. So we'll start with the literature review, just a brief introduction. Acute ischemic stroke occurs around 34 of every 100,000 deliveries. At least one half of the pregnancy-related stroke are ischemic in etiology. Pregnant and postpartum women, unfortunately, are excluded in almost all randomized controlled trials. That's why there is a lack of evidence on the actual benefits of the reperfusion therapy in this population. Now, until 2015, the FDA has labeled IV thrombolysis for pregnancy as a red flag. However, in 2018, the AHA introduced their new guidelines, and then when pregnancy was first considered to be eligible for IV thrombolysis with a class evidence of 2B. Now, in their most recent guidelines, they have also continued to consider them eligible for thrombolysis and actually listed them in the patient list where benefits equals to risk with individualized decision-making prior to going through the thrombolysis. Now, when we come to the ESO recommendation, we see that there is a guideline specifically on stroke in women where they highlight that across their recommendation that the evidence-based recommendation based on available data cannot be done. However, what they have done is they relayed on the expert consensus in these following statements. So in postpartum women, a pregnant woman with acute disabling stroke who are otherwise eligible for IV thrombolysis, they said that clearly you assess the benefits versus the risk, and based on this, patient can go through IV thrombolysis. The same was done for mechanical thrombectomy. They had the same conclusion: when you have the benefit outweighs the risk of uterine bleeding, then you should always consider mechanical thrombectomy. And then when it comes to bridging therapy, here where we have them specifically stating that once you have the decision to go for bridging therapy or MT alone, then MT is more favorable to proceed with. Now, coming back to our case, fortunately, what we have done is actually stick to the guidelines, and patient only underwent mechanical thrombectomy. Here, this is the CT angiogram of the patient, cerebral angiogram of the patient pre-mechanical thrombectomy. We can appreciate the right MCA occlusion. She underwent mechanical thrombectomy, and we achieved a complete reperfusion of this patient. Patient had very good recovery. She went back to her baseline. We did a uterine ultrasound. Alhamdulillah, it showed viable fetus with pulsating heartbeat. On her follow-up, patient had a normal vaginal delivery and with no complications, not to her, not to the baby otherwise as well. So I came across this interesting an interesting study that addresses the major evidence gap that we have from the reperfusion trials. In this study, what they did is they studied pregnant or postpartum females with ischemic stroke and non-pregnant females with ischemic stroke who were registered in the Get With the Guidelines registry from the period of 2008 and 2013. And then from that, they wanted to see what were the actual differences in these two categories. They identified the acute reperfusion, whether it's IV TPA, whether it's catheter-based thrombolysis or thrombectomy as a management. So the baseline result were the pregnant women or postpartum women were usually younger and had a greater stroke severity at a baseline or on admission. When we can see here in this graph, the green is basically non-pregnant women with ischemic stroke, while the red is pregnant women with ischemic stroke. And we can see that usually the red is more higher in patient who is younger between the age of 25 up to 39, while above 40, this is where you have the tendency to have acute ischemic stroke in those who are non-pregnant. Now, they had similar acute stroke reperfusion therapy. However, when they looked at the use of IV thrombolysis, they saw that it was less used in pregnant women or postpartum women who might have been eligible. And one of the primary reason for not using the IV TPA was pregnancy on its own. The second reason was recent surgery, could be, which was basically the cesarean section. There was also a trend toward increased symptomatic intracranial hemorrhage in pregnant or postpartum female who actually received the tissue plasminogen activator. However, it's important to highlight that these patients have different contexts. So in patient who is pregnant, we know that she's presenting with a median initial stroke severity that is higher. She's undergoing the hemostatic changes of pregnancy itself. So there are a lot of confounding factors for this increase of hemorrhagic transformation. We cannot solely say that this is due to thrombolysis itself. However, stating this all in all, there was no life-threatening bleeding, there was no in-hospital death. They had similar rates of discharge to home, which are all reassuring and in favor of the use of IV thrombolysis. Now, the pregnant or postpartum women were less likely to have traditional stroke risk factors such as diabetes, previous stroke, or hypertension on admission. And this just probably due to the age where they are younger, while non-pregnant, they were older in age. Additionally, it just emphasized on the pregnancy or postpartum period being a very hypercoagulable state itself. Now, on data on the timing of pregnancy were available for only 145 of the 338 patients who were pregnant or in the postpartum period, and it showed that it was highest in the postpartum period and then followed by the antepartum period. However, it was around 2% only during delivery. Now, my take-home message here is that pregnant and postpartum women with ischemic stroke should not be excluded from reperfusion therapy just due to the pregnancy or the postpartum state. What we need is a multidisciplinary, individualized decision-making, which is quite essential in these patients. And I would like to conclude my presentation here.
Excellent, Dr. Salama. You are over time by 1 minute. Very quick question. Did we know the etiology of the stroke for this young lady?
No. So in this specific study, they did not go through the etiologies because
Your patients?
My patient, no, because she underwent vasculitis, workup, thrombophilia, echo, Holter monitoring, all were negative.
Okay, very interesting. I remember when they did the MT for this lady, it was a white tissue type of clot. It looks like a part of the valve that she had it, but she had another 2 pregnancy after this one, Dr. Nuran, normal delivery. So she has total of 3. I took a consent from the patient and her husband at that time when she presented that the baby will, if the baby came a male, they will call him Suhail. If a female, they will call him Suhaila. But unfortunately, I didn't get any of these 2 names. But
actually, they should have done this. Yani. I would do this. Well,
Thank you.
it's really difficult to deal with pregnant women because you are not dealing with one, you are dealing with two. But very good outcome, alhamdulillah.
Alhamdulillah.
So if you
Thank
allow
you,
me,
Dr. Salma.
yeah, if you allow me, Prof. Suhail, I will be presenting Dr. Muhannad Asiri, our next speaker, and he will be talking about another interesting case that he faced. Dr. Muhannad, he is a stroke neurologist and associate consultant that just joined us in the Ministry of National Guard in Riyadh. We are so lucky to have him. Dr. Muhannad, he finished his Saudi neurology board in 2023, so he's quite young, and he just finished his vascular fellowship completed at King Faisal Specialist Hospital in Riyadh. So without further ado, Dr. Muhannad, you can present your case.
Assalamu alaikum. Thank you, Dr. Nouran, and Prof. Suhail, and all the panelists and the organization committee for inviting me. I hope inshallah to be a good ad. So my presentation a little bit longer than previous presentation, need concentration, caffeine, I assume IV caffeine. So basically this lady, 68 years old female patient with history of diabetes, hypertension, and history of a prior stroke in 2022, presented with right MCA stroke. This patient diagnosed at the previous stroke with AFib. Since then, she on apixaban 5 milligram twice daily. Unfortunately, she presented late due to lack of reperfusion therapy at Periphery Hospital with an IH score of 16. So basically,
Dr. Muhannad, can you make sure that you put your presentation on the slide mode, so like a full slide screen?
Okay, so it works now?
Yeah, we can see the CT scan now.
Okay, perfect. So can I continue now? It's clear?
Yes, but I believe that your slides are smaller than the usual. What do you see, Prof. Suhail, from your side?
Yes, I think if you if you will be able share, then share it again. Yes. Now we can see it. Just continue.
Now it's clear.
Perfect. So this basically the brain non-contrasted CT shows right MCA stroke with hemorrhagic transformation, grade 2. So CT angio show that a lot of abnormality, mild atherosclerotic changes, no significant intra or extra stenosis. Initial admission and workup include hemoglobin A1C was uncontrolled, LDL to around 2. Transthoracic echo was show no clear abnormality. So we were thinking about what the next step of management. Do we consider this as DUAC failure and switch to another DUAC, or go to vitamin K antagonist, continue apixaban without change and accept this kind of failure, or add aspirin on ongoing DUAC, or looking for further investigation beyond routine workup in this age group? After all of this, when to start antithrombotic? So all this question raised during the first 24 hours. Our differential diagnosis was DUAC failure or pseudo DUAC failure, include alternative embolic mechanism, other cardioembolic source, valvular related AFib, hypercoagulable, cancer related, or medication and adherence. Despite patient report, she was on apixaban full dose till like 8 hours prior to stroke onset. So hospital course basically was apixaban held. We start her on aspirin 81 milligram and follow-up, planning for follow-up CT after 4 days to think about resumption of anticoagulation. At second day, patient being less arousable afternoon, no clear focal neurological deficit or significant NIH score change. So MRI was scheduled at that time and showed left MCA distal like impuli over the MCA territory. So we have recurrent stroke within like 2 days for this patient. MRA wasn't show LVO. There is distal M2, left to M2 occlusion. So further diagnostic workup include urgent transthoracic echo, lower limb Doppler, PET scan, hypercoagulable workup, autoimmune panel, and blood culture and serology, just to rule out any kind of infective endocarditis. So echo was showed small mobile mass attached to valvular surface without any clear etiology. Rather than this, all the echo report were normal. So work results, lower limb Doppler was negative, PET scan was bending, but subsequently was negative, hypercoagulable panel, no clear abnormality, and autoimmune, and even the blood cultures prelim was negative. So given patient hemorrhagic transformation grade 2, we have a lot of choices. So either continue to hold therapeutic anticoagulation, restart DUAC again, apixaban, same medication, or initiate either low molecular or unfractionated heparin. Also, we thought about start antibiotics, assume this vegetation related to and attached to valve. However, after discussion with cardio, they thought most probably were mass. So multidisciplinary meeting done with cardiology, cardiac surgery, and their differential diagnoses include primary cardiac tumor, metastatic cardiac involvement, infective or non-infective vegetation, or thrombus, or calcification. So they agreed and consensus to continue on a low molecular weight heparin and go for MRI and cardiac MRI. So we start patient on low dose unfractionated heparin and kept on stroke unit. Cardiac MRI shows small valvular attached mass attached to mitral valve with undetermined etiology. So what do you would like to do next? So we have either surgical resection with long-term anticoagulation with either DUAC, vitamin K, or heparin, or antiplatelet after resection, or long-term anticoagulation without lesion resection, or a long-term antiplatelet alone. So cardiology and cardiac surgery per se say less likely this tiny small lesion lead to this recurrent kind of strokes. However, consensus of all the team, including stroke neurologist, to proceed with a lesion resection as long as the clear abnormality we had so far. So patients subsequently being on full therapeutic enoxaparin on day 7, anticoagulation just held for hematuria for 2 days, and patient went through the infection process and aspiration pneumonia, so surgery postponed for 2 weeks. However, 2 weeks later, after a CT, patient had brain CD just to make sure pre-cardiac assessment. So that CT shows new left PCA territory subacute infarction, despite patient was on full therapeutic enoxaparin. So assessment in that moment was an NIH score of 15, patient oriented, dysarthric, and echo showed same small lesion and mobile mass attached to the valve. So what the next step? Do you want to proceed for surgery or just hold surgery and keep the patient on anticoagulation?
1 minute, Dr.
Okay, sure. 2 days later, surgical resection done, and histopath confirmed the lesion was papillary fibroelastoma. So patient was maintained on unfractionated heparin, then apixaban as long term. She underwent for physiotherapy, extensive physiotherapy, then over 1 year, no any recurrent stroke. When we look for the literature, not a lot of data about papillary fibroelastoma as related to stroke. However, two things mentioned worth to mention, which is high rate of stroke with this kind of lesions, and most of the lesions were 1 centimeter or less, so it's tiny lesions, and offer the management of this papillary lesions. All of them go toward case reports, go toward resection and long-term anticoagulation. Thank you.
Thank you, Dr. Mohanad. Quite difficult case, I would say, and quite interesting. So, Prof. Suhail?
Shukran, Dr. Mohammed. Thank you. So, welcome everyone back again. We are going now to the program, and I'm so delighted that the attendees that they are so interested also with Dr. Mohammed and Salama cases. So, I will go to the first lecture by a distinguished speaker, Dr. Aaron Rosenthal, who's going to speak about the cryptogenic stroke workup and what next. Just a brief introduction about Dr. Aaron. He's a assistant professor of neurology at hospital of the University of Pennsylvania. Also, he did his training at Yale University and a master's degree in epidemiology from University of Pennsylvania. His research interest area mainly focusing on stroke prevention, stroke recovery, and post-stroke cognitive impairment. Welcome, my friend, Dr. Aaron.
Thank you so much. Let me share my screen here. Okay. Can you see it okay?
Yes, you are good.
Terrific. Okay. Well, I'm so delighted to be here. Thank you for having me. I'm going to talk a bit about cryptogenic stroke workup and what's next. I have no disclosures. As probably a lot of us know, we think about ischemic stroke in terms of subtypes, and large artery, atheros, small vessel disease, cardioembolism. These each account for, something like 15-20% of ischemic stroke subtypes. And then there's a small sliver of other stroke subtypes. And then there's cryptogenic, which is about 30% of ischemic stroke subtypes. So what are these other kind of ischemic stroke subtypes that I'm kind of referring to, that small sliver there? Well, it's a real grab bag of things. It's drugs like cocaine, or infections like syphilis, genetic disorders, CADASIL, vasculopathies like dissection or moya-moya, and then even, prothrombotic disorders or hypercoagulable states such as antiphospholipid antibody syndrome. So these are all in the other category, other determined causes. And why does this all matter to us? The reason it matters is that it determines our secondary prevention strategies and how we approach preventing another stroke. So for large vessel athero, we can think about revascularization of a carotid with stent or a carotid endarterectomy, in addition to using antiplatelet agent. For cardioembolism, especially if we're thinking about secondary to AFib or severely reduced ejection fraction, LV thrombus, we think about anticoagulation, small vessel disease, antiplatelet agent. And, a lot of this is sort of on top of risk factor modification, quitting smoking, lifestyle modification, exercising more, in addition to statin to reduce cholesterol. And so that all that is pretty standard and straightforward. And I would say this is even true for some of the other that small sliver of other categories. So if you think about, let's say, antiphospholipid antibody syndrome, well, it's clear we need to anticoagulate for secondary prevention. For syphilis or zoster, there's a clear treatment, whether it's antibiotics or antivirals. So again, knowing the cause of the stroke is really important when we think about secondary prevention. I don't think I'm saying anything new there. Now, the cryptogenic stroke basket is kind of important, mostly because it means we just don't know. And it would be helpful, I think, for us to start with a just quick case to illustrate what I'm talking about. A 68-year-old man comes in with mild left face and arm weakness, mild neglect. Some risk factors: hypertension, prior smoker. And on the MRI, you see a small kind of high right cortical infarction. Vessels look okay. EKG looks good. The echo maybe a slightly reduced EF, but for the most part, there's no problem there. And the labs look okay too. So what's going on here? And this would be kind of classified as a cryptogenic stroke. And so how do we think about secondary prevention for cryptogenic stroke? And there's a big question mark there. Cryptogenic stroke is a kind of large wastebasket of things. In some, it basically means we don't really know why the patient had a stroke, but that can be due to many factors. It could be that our workup's incomplete. And so people often forget that cryptogenic stroke can also mean that you just didn't do a complete workup to understand what was going on. It could mean that there are multiple possible causes. So a patient can have a large artery athero that's, a carotid that's stenosed 70% plus AFib. Who knows which one was the actual issue sometimes. It could be that you've done a thorough but negative evaluation. And it could be that there are leftovers from the known cause categories that don't quite fit. So a patient had AFib, small run of AFib, maybe a couple of years ago, hasn't had it since, doesn't really quite fit for a new stroke. So cryptogenic stroke, again, very broad kind of category. And what we're going to do for the rest of the lecture, or at least for some of the lecture, is talk about ESUS. Now, ESUS is basically a subtype of cryptogenic stroke, and I'll kind of get into the actual definition of it. But I think that is kind of the main kind of meat of cryptogenic stroke. So the question is, how thorough is thorough workup? Because that obviously determines, cryptogenic and even ESUS. So the basic things, history and exam, carotid ultrasound, EKG, telemetry in the hospital, echocardiogram, routine blood tests. It's pretty standard, pretty straightforward workup. And then there's, insufficient evaluation may mean that we didn't do some of those things, but then there's a thorough but negative evaluation. And how thorough is thorough? Well, intracranial vascular imaging, maybe that should be part of the basic workup. But if that's not done, for sure, I would say it's an insufficient evaluation. And then you get into really the kind of deep recesses of a comprehensive stroke workup. TEE, or transesophageal echo, prolonged cardiac telemetry with loop recorder link, prothrombotic testing for antiphospholipid antibody syndrome, toxicology to look for cocaine use or amphetamine use, lumbar puncture to look for CSF testing. And this, you've done all this stuff. This is a really kind of comprehensive workup. And the reason that this matters is because it brings us into the question of ESUS. ESUS means that you did do a thorough workup. And after the thorough workup, here's kind of what you have left. There's a stroke on imaging. It's embolic appearing. It's cortical or large, and it's not in the distribution of a small penetrating cerebral artery. There's an absence of moderate or severe extracranial or intracranial atherosclerosis, and we define that based on a 50% or more. So if it's less than 50%, that means there's an absence of moderate or severe athero. There's no major cardiac source of embolism, so no AFib, no eflutter. The EF is not less than 30%. And there's no other specific cause of stroke identified. So the vessels don't look like someone has vasculitis. There's no vasospasm. There's no drug misuse. And so all embolic strokes of undetermined source, all ESUS is cryptogenic stroke, but not all cryptogenic stroke is ESUS. So I'm going to spend the rest of the talk talking about ESUS because I think that is the most interesting aspect or the most interesting subcategory of cryptogenic stroke. The question is, what do we do for ESUS? You do this workup, nothing shows up, and you meet the criteria here. Well, there's been a lot of debate over the last 10 years about how we kind of deal with this. And one of the major suggestions was, well, do we just anticoagulate ESUS? Is that the proper approach here? And so there were multiple trials over the last decade that looked at this question with different anticoagulants. There was Navigate ESUS that looked at rivaroxaban or Xarelto versus aspirin, and that was terminated due to lack of efficacy. There was RESPECT ESIS, which was dabigatran versus aspirin. And then there was Arcadia, which tried to enrich the trial population from Navigate ESIS and RESPECT ESIS and just looked at patients with some sign of atrial cardiopathy or atrial abnormality. And that was presented at ESOC only a couple of years ago. And so what did all of these trials show us about anticoagulation for ESIS? Well, Navigate ESIS was negative. As you can see there, not only is the confidence interval indicate that the results are negative, but the p-value indicates that the study was negative. And the stroke rate, the other thing to keep in mind here, the stroke rate is actually quite high. I mean, you look at that stroke rate, it's about 4 to 5% per year with ESIS patients, and multiple trials have kind of shown this. So Navigate ESIS is negative. What about RESPECT ESIS using dabigatran versus aspirin? And here too, again, you can see with the confidence interval and the p-value, this was negative. And again, once again, 4 to 5% per year recurrent stroke rate. And how about Arcadia, where we enriched that population to look at a left atrial cardiopathy? Here too, again, totally and completely negative. So all these ESIS trials failed when comparing anticoagulation to aspirin for secondary stroke prevention in ESIS. And why did they fail? And what next? Well, maybe it's a question of design. And I submit that this is the primary issue here. So maybe the ESIS concept is dumb, for lack of a better word. Maybe ESIS really just isn't specific enough. There's a question about whether we use the wrong drug, the wrong dose. Well, we tested multiple anticoagulants, but maybe there's need for a dual agent. So maybe that's a possibility in the future. Did we enroll the wrong patients? Well, we tried to enrich the population with Arcadia, and that didn't seem to work. Did they abort too soon in Navigate ESIS? Well, Arcadia didn't abort too soon. So I don't think that's the issue here. So ESIS is, I think, just more heterogeneous than we thought. It contains different patient populations that probably shouldn't be mashed together into one category. And we can't really shoot first and ask questions later. So we can't just test all these patients, anticoagulant versus antiplatelet, and then say, okay, we're done. And we can ask some other interesting questions later that are just for academic purposes. We may need to actually dive into the subgroups here. So let's dive a little bit into ESIS here. And here are just a lot of kind of subcategories. I'll go through some of these. The first one maybe I'll cover is the PFO question, because that initially had fallen under the ESIS category. But, recently, I would say years ago, the ROPE score was developed to stratify patients with a PFO and determine how likely it was that the stroke was due to PFO. And the higher the ROPE score, max of 10, min of 0, the higher the ROPE score, the more likely the stroke was due to the PFO itself. And you can see what the ROPE score consisted of is, basic risk factors, whether it was cortical infarct, the age of the patient. And it's been pretty clear over the course of years that PFO that is open and the stroke is likely due to PFO ought to be closed, because closure leads to reduced risk of recurrent ischemic stroke. That's just kind of been shown over and over again. Recently, the ROPE score was enhanced by this Pascal classification system. Now, the Pascal classification system looked at PFO anatomy rather than just the risk factors of the patient, the age of the patient. So if there's a large shunt, an atrial septal and or an atrial septal aneurysm, that makes it more likely that the stroke is due to PFO. And so we now use both the ROPE score and the Pascal classification system to determine whether to close the PFO. So a lot of old ESIS probably was just PFO-associated stroke, or maybe not a lot, maybe some, but definitely PFO-associated stroke was initially categorized as ESIS, and now we probably should exclude it from ESIS because we know that PFO is in some ways the source for some of these patients. So that's just an example of why ESIS is maybe too broad of a category here. Let's dive into maybe some other categories of ESIS and take away the PFO. Maybe we're actually missing AFib in some of these ESIS patients. Is that possible? So there is some biological and genetic plausibility. We know you have improved detection with prolonged monitoring. Maybe we need to look harder for AFib in the patients who, have a short-term monitor and don't have AFib, or there's no AFib on the telemetry in the hospital. But there's a little bit of a logical fallacy in that argument, or a hole in that argument, I should say. If anticoagulation is highly effective for AFib, but not for ESIS, then it's probably unlikely that anticoagulation or the AFib is the reason that ESIS patients are having stroke, right? So it just doesn't quite make sense. But maybe let's dive into this a little bit, because I do think it's still relevant. There was the LOOP study, which was done a few years ago, that looked at patients who were high risk for stroke. And they did an implanted loop recorder versus usual care, whatever usual care that was. And the patients with the implanted loop recorder were found to have a 3x AFib detection rate, 8% versus 2.5% per year. And most of those were treated with anticoagulation. However, there was no significant reduction in stroke, even though you caught more AFib and ended up anticoagulating more people. So there's something here. Maybe not all AFib is worth screening for. Maybe not all detected AFib merits anticoagulation. Where do we draw the line here? Well, there were two other trials that kind of looked at this question, both published in New England Journal of Medicine. This trial, anticoagulation with edoxaban in patients with atrial high rate episodes. And atrial high rate episodes basically are patients with AFib, although there's not perfect overlap there, depending on the cardiologist you ask. And they randomized patients to edoxaban or placebo. And they actually found there was no benefit to anticoagulation in these patients with atrial high rate episodes. Now we get to the Artesia trial, which was only recently published. And they took patients with proven AFib 6 minutes to 24 hours detected by PACER, ICD, or ILR. They were randomized to apixaban or aspirin, apixaban the best DOAC, and stroke risk was reduced by 0.46% per year. However, major bleeding increased by 0.77% per year. So is the trade-off really worth it here? I don't know. What they ended up doing was a subgroup analysis looking at the patients who had had prior stroke or TIA, and that was about 9% of the trial population. And in that population, it was clear that apixaban was better than aspirin, or significant reduction in stroke rate. So all this is to say that we don't quite know what to do with patients when you don't find AFib right off the bat, or at a 30-month short-term, short-duration monitoring. Probably some of these patients who are categorized as ESIS have AFib and merit anticoagulation, but it's also possible that some of them do not, depending on the duration of the AFib, when it's found. And we really kind of have to figure out whether monitoring more is actually worthwhile or whether it's not. Sometimes looking for answers leads you to more questions, and sometimes you're better off just not knowing. So again, there's a lot to kind of figure out there. Let's go back into the kind of ESIS grab bag here, and we can think about left ventricular dysfunction, because maybe some of these patients who have a slightly reduced EF actually do merit some kind of alternate treatment. Maybe it's anticoagulation. And so we look at Navigate ESIS, which did and the authors did kind of a subgroup analysis of patients who had left ventricular dysfunction, that is an EF of less than 40%, or some kind of regional wall motion abnormality. And Xarelto was clearly superior in that patient population. Now, again, it was only 7% of the people in the trial, so I'm not sure that we can definitively say something about this, but maybe there's another trial that's needed for just left ventricular dysfunction. The ESIS patients with left ventricular dysfunction, perhaps they are the ones who need anticoagulation, but not the rest of the ESIS folks. So again, more questions here. What about large vessel athero that's not moderate or severe stenosis, so substenotic plaque? The carotids, you may say, well, it was unlikely to be due to large vessel athero because it's less than 50% stenosis. But what if that's not the case? We know that recurrent stroke is more likely to occur ipsilateral to plaque, even if the plaque is less than 50% stenosed. So perhaps in this ESUS category, these patients with substenotic plaque actually do merit some kind of treatment. Maybe it's intervention, maybe it's prolonged dual antiplatelet, kind of unclear. But what is clear is that the substenotic plaques matter when we think about causes of stroke. In particular, there are certain characteristics of plaque that matter. We found that intraplaque hemorrhage has the highest risk of recurrent stroke when we're thinking about attributing stroke to plaque. Then there's ulceration, calcification, lipid-rich necrotic core, thin ruptured fibrous cap, inflammation or hypermetabolism. These are all things that make a plaque higher risk than their kind of regular counterparts. And we kind of have to stratify these risk factors within the plaque. Maybe we need more advanced imaging to kind of figure this out, whether it's MRI, vessel wall imaging, PET. Maybe we do look at the CTAs a little more closely. What is clear, though, is that this carotid disease population with, let's say, intraplaque hemorrhage, likely we need to pay more attention to that in patients who we categorize as ESUS, because maybe that matters actually a bit more. What about cancer and stroke, which is still technically ESUS, even though sometimes we'll say hypercoagulability of malignancy is the cause? Again, very clear that the incidence of arterial thromboembolism is higher in cancer patients, in particular as the stages kind of increase. And advanced cancer is clearly a risk factor for stroke. In all the ESUS patients, should we be screening for cancer? Should we be doing CAT scan of the chest, abdomen, pelvis? Some people do that. It's individualized based on kind of, I think, the attending sometimes or the D-dimer level. But maybe that makes up some of the ESUS population as well. And they might merit kind of separate treatment with treating the cancer or anticoagulation with either Pixaban or Lovenox, or maybe aspirin is actually just as good. So we don't really know. I think we kind of have to figure that out. So that is the just to give a sense of the grab bag of ESUS, right? We tend to think of it as one thing, but it's actually multiple things. And I will just say, just hot off the presses, presented at the International Stroke Conference a week ago, Factor XIa inhibitors might have a role here. So Oceanic Stroke was a trial that randomized patients to asundexian, a Factor XIa inhibitor, plus antiplatelets versus some antiplatelet regimen without asundexian. And there was clearly a significant risk reduction in stroke without an increased risk of hemorrhage. And a third of these patients were patients with a stroke of undetermined etiology, so possible ESUS patients. And so maybe that is part of the answer here to treating ESUS. So all in all, cryptogenic stroke, still too hot. We still don't know enough. We need to do a lot more research on the anatomy, pathology, biomarkers, vascular imaging. We need to move beyond DOACs for these patients, and maybe Factor XIa inhibitors are the answer. Thanks so much.
Great. Thank you, Dr. Rosetta. It's very interesting the way that you approach that one, putting all these circles, showing if one is dropped, but still that there's a question about that circuit which has been dropped. I believe there will be many questions at the end. So let us to go for the second speaker, then we are back. Well, Dr. Nurat, stage is yours.
Okay, yeah, thank you, Dr. Aaron. Very interesting. And it's actually my honor to present Prof. Cheryl today. She will be talking about primary prevention of stroke from guideline to the clinical practice. Prof. Cheryl, she is a professor of neurology, and she is the director of the Center for Transformative Stroke Care and the chair at the American Heart Association Stroke Council. And welcome, Prof. Cheryl. So glad to have you today. The floor is yours.
Thank you so much for the invitation. It's really an honor to be here. Can you see my slides okay?
Yes?
Yeah. Okay, good. And you can see this presenter view? Okay,
Absolutely.
excellent. I just want to make sure. Okay, well, I'm going to be talking about the primary prevention of stroke from guidelines to practice. And the goal today is these are my disclosures, but the goal is to describe kind of the forecast of stroke up to 2050. And this is why we need to be focusing on primary prevention, to summarize the lifestyle and behavioral recommendations from the guidelines and the risk factor management, and then provide some recommendations for implementation in clinical practice. And so the forecast is pretty dim. It actually, you can see the green here is stroke, and you can see that the prevalence and the number of people with this condition is going to increase significantly from 2020 to 2050. So from about 4% in 2020 to over 6.4% in 2050. And this is just the US alone. So I'm sure that worldwide we're looking at a very, very large population of people with stroke. And then, of course, the number of cases will increase as well. And this is data from a brand new scientific statement that is about to be published, focusing on women. And it also shows both sexes, but in women in particular, the prevalence of stroke will increase from 4.1 to 6.7%, and there will be 5.3 to 10.4 million individuals who are women that will have a stroke. And this is even higher than men. So I think this is an important statistic to keep in mind, and the reason for this, I'm sure, is because women live longer, but we definitely need to be working on prevention in women in particular. And then if we break it down by age and race, ethnicity, you can see at each age group will go up in both the numbers and prevalence of strokes. And this is true for the majority of the ethnic groups as well. So definitely, again, a coming epidemic of stroke. So as far as primary prevention in the guidelines, why did we do it now? Well, the initial guidelines, or the most recent guidelines prior to 2024, were published in 2014. And then I was privileged to be writing group chair for the first and only guidelines for the prevention of stroke in women. And this was also published in 2014. And so over 10 years had gone by the time both of these were, this next guideline was published. There's been a lot of literature, and that women-specific issues needed to be incorporated into the primary prevention guidelines rather than just having their own guideline. So the background and rationale was that we know what the modifiable risk factors are. They account for about 90% of the population attributable risk for stroke. That even in younger individuals, we have specific risk factors that we know, like binge drinking, hypertension, a variety of other biomarkers, psychosocial stress, smoking, and increased waist to hip ratio. And we already know how to prevent it. We can deal with a lot of these risk factors. They are modifiable. And we also know that preventing stroke will improve overall brain health, which is incredibly important. Most people worry more about dementia than having a stroke. And that we should really start preventive measures early. So we included the entire lifespan in our guideline. So we have our current state of risk factor control, and we have an achievable control with better implementation of available proven strategies. But we just have to bridge between those two goals. And so we have the opportunity to reduce the burden of stroke on patients, communities, and society, present modifiable factors that allow us to address disparities. And all of these things underscore the imperative for quality improvement and health services research to improve risk factor detection and control. And so we know there are barriers, and I'm sure that this is even more so in lower and middle income countries and places where we know there's poor access to care and socioeconomic disadvantage. But the other important things are lack of social and community support, poor access to education, and racism and discrimination. So those are some of the adverse social determinants of health. But then we also have inadequate management of common risk factors. They're undiagnosed, they could be untreated. Best practices may not be followed. There could be a lack of shared decision-making and health system barriers. And sometimes there's a de-emphasis on lifestyle factors. It's easier to prescribe a pill. So the other thing that we wanted to address in this guideline is some of the commonly unrecognized risk-enhancing factors like migraine, endometriosis, early menopause, and adverse pregnancy outcomes. So we'll cover some of those in this overview. So this is just the commonly presented figure of all of the different social determinants of health and health-related social needs. And so I think all of these things can impact the ability to deliver adequate primary prevention of stroke. So I'm going to go through a highlight of some of the guideline recommendations now. And the first one really is emphasizing screening. And so in persons who are 40 to 79, we estimate that the risk of heart disease and stroke should be estimated every 1 to 5 years. And then this is a great guide for instituting further workup or lifestyle recommendations or treatment. And then for people who are 18 or older, periodic screening for the modifiable behaviors and medical conditions is recommended. And then in folks who are 18 and up, periodic screening for social determinants of health. Going around the circle of the AHA's Life Essential 8, we have first, diet quality. And so we recommend a Mediterranean diet. And of course, to this audience, that may or may not be something that is already frequently served on the table. But of course, this was tested in randomized controlled trials and has a class of recommendation of a 1. And then for those who are 60 or older and have uncontrolled blood pressure, we recommend salt substitution. It's reasonable to reduce the incidence of stroke. The next is physical activity. This is a difficult one for physicians to talk to patients about sometimes because there's not a lot of time in the visits to talk about physical activity and exercise. But we do recommend screening for it. We recommend getting at least 150 minutes of moderate intensity or 75 minutes of vigorous intensity physical activity per week. And this is a new recommendation, class 1, to counsel to avoid excessive time spent in sedentary behavior. And this is something that has become much more evident in the literature, that the more people spend sitting, the higher their risk of having a stroke and cardiovascular disease. So blood sugar, in this one, of course, we recommend screening for diabetes. And the second recommendation is for the use of a GLP-1 receptor agonist in patients with diabetes and high cardiovascular risk or established cardiovascular disease. There was no real benefit from intensive glycemic control in terms of stroke prevention. And then weight and obesity, we recommend screening, of course, for people who may be overweight. And then the evidence showed that bariatric surgical procedures may be considered to reduce the risk of stroke in people with obesity class 2 and above, which is a body mass index of greater than 35. So there's obviously the GLP-1 receptor agonist that could be included here. At the time of the guideline, we did not have the data that would clearly put this in as a recommendation based on the trial data thus far. Blood pressure, obviously the most modifiable risk factor for stroke. We recommend screening for hypertension. For people who have stage 1 or 2 hypertension, lifestyle modification, drug treatment to a target of less than 130/80 is recommended. And then, of course, thiazide and thiazide-like diuretics, ACE inhibitors, calcium channel blockers, and angiotensin receptor blockers are also recommended. And then I think this one is really critical. This was new and is consistent with the new blood pressure guidelines that published in July of 2025, which is that drug therapy for patients with at least stage 2 hypertension, they're almost always going to require 2 different medications, and that delivering that in one single pill can be extremely effective. And so that's an alternative to just having 2 pills. So there's a whole scientific statement that's recommending the single pill combination therapy as well. And it is much more efficient and effective at getting blood pressure under control. So obviously we recommend smoking cessation or never starting smoking. This is a level 1 recommendation for behavioral counseling, and for active smokers, assistance with cessation is recommended. Now that we did not recommend vaping or electronic cigarettes for this purpose. And then sleep. So this is really the 8th part of the essential 8. And right now, in our recommendation, the time that we had that data, the effectiveness of screening adults for obstructive sleep apnea to prevent stroke in particular was unclear. So that was a 2B. And for people who have obstructive sleep apnea, continuation with positive airway pressure treatment maybe, or CPAP may be reasonable. But there was no clear guide for the ideal sleep duration, although I think that there is some data out there. It's just that this wasn't pertaining to stroke specifically. So migraine is an important risk enhancing factor, I should say, for stroke. It's linked because of migraine with aura in particular has been associated with stroke risk. There's an association that's stronger for ischemic than hemorrhagic stroke. Vascular risk factors are common in people with migraine, and the use of combined hormonal contraception in those with migraine with aura is associated with an increased risk. And so our recommendations are that folks who are 18 to 64 with migraine with or without aura, that all of their risk factors be evaluated and modified as appropriate. And then also for folks who have migraine with aura, who desire contraception, progestin only or non-hormonal forms are recommended. For those with substance use disorders, we feel that screening for this is important to inform stroke risk, and also counseling to stop or appropriate substance use disorder treatments is reasonable to reduce stroke risk. So we did spend time on women-specific factors, and I know we heard a case earlier of pregnancy and stroke. And so what we recommend is specifically blood pressure treatment in women who are pregnant and have a blood pressure of 160 over 110, and that they need to have their blood pressure lowered as soon as possible in that situation to reduce the risk of fatal maternal intracerebral hemorrhage. And then a 2A recommendation is for those who have hypertensive disorders of pregnancy to lower blood pressure to less than 140 over 90. And there is clinical trial evidence to show that you can reduce the risk of severe preeclampsia by lowering blood pressure. So there are a lot of adverse pregnancy outcomes that are well established and all have an increased risk of stroke, not only during pregnancy, but later in life. And so this is an algorithm that Dr. Eliza Miller put together, who wrote this section of the guideline. And so if you're screening for women who have been pregnant, you can ask them, did they have pregnancies that were affected by a miscarriage? And if there's 2 or more, then you evaluate and manage their risk factors. If they have pregnancies affected by any one of these other adverse pregnancy outcomes, then again, evaluate and manage their vascular risk. So I think this is a great way to just remind us all that a lot of times we don't think about what happened to a woman during childbearing years. especially if she's in her 50s or 60s, but this could be important, and especially for primary prevention. And then endometriosis is another condition that's recently become clear that it has an association with stroke risk. And this is because it can increase the risk of hypertension, hypercholesterolemia, inflammation, and cardiovascular disease. And so we recommend screening for a history of it, and also risk factor evaluation and modification of these risk factors are reasonable. And hormonal contraception, again, is something that we typically include in these guidelines. Lower doses of estradiol are recommended. And then for those who are higher risk, shared decision-making is recommended. We generally have recommended progestin-only or non-hormonal contraception to reduce the risk of stroke. Menopause. These are new recommendations. Screening for premature ovarian failure, which is menopause before the age of 40, or early menopause, which is before the age of 45, can be beneficial to inform stroke risk. And we feel that recommendation is to evaluate and modify vascular risk factors. And then again, we recommend against hormone therapy in people who are 60 or older, more than 10 years post natural menopause, or at an elevated risk of cardiovascular disease or stroke. And then for those who are undergoing transitions in gender, women, transgender women and gender diverse individuals taking estrogens for gender affirmation are at an increased risk based on some large data sets. So we recommend modification of risk factors. Men, however, who have confirmed hypogonadism and are considering testosterone therapy, initiation or continuing testosterone replacement is reasonable and does not increase the risk of stroke. So if we can actually impact these risk factors, we could make a big difference in the risk of stroke in the population. So if you look at the blue bars here, this is the published targets for healthy people 2030, which is a reduction in hypertension, diabetes, and obesity by 10%, and risk factor control increased by 20%. So you could have basically about a 17% reduction in the risk of stroke. And if you look at the yellow bars, these are aggressive targets of reducing obesity by half and risk factor control by 40%, you could see about a 37 to 38% reduction in stroke if we were actually able to accomplish that. So I think there are some applications of the guidelines in clinical practice that we could talk about. Of course, dissemination is important. Public health departments, faith-based organizations, other healthcare settings, schools, colleges, workplaces, places where we can impact younger people who are probably not aware of their potential risk for stroke later in life. And then I think we could consider ways to incorporate lifestyle coaching into care settings where possible, like primary care. Focus on physical activity more, reducing sedentary behavior, encouraging weight loss and improving diet, and then obviously reducing areas that may have food deserts, addressing neighborhood safety and walkability. And then for the sex-specific primary prevention, identifying these risk factors is an overarching rationale where we just don't have randomized controlled trials. The level of evidence may be relatively low, so we need to keep doing work in this area. But community awareness and dissemination via groups primarily made up of and run by women is really critical. Electronic health record best practice alerts for screening women, and some of this is being implemented in our area in Charlotte, North Carolina, and then designing implementation strategies for each setting. So I think that in summary, we can prevent 80 to 90% of strokes if we just screen for and identify the risk factors. Life's Essential 8 is one way to do that. The primary prevention guideline is also looking at the lifespan and emphasizing women's health and pregnancy history. And the guideline has been inclusive, And we really think that social determinants of health should also be a part of the screening. So I will end there, and I thank you for your attention.
Okay, thank you so much, Prof. Cheryl. And I think all of us do believe that prevention is better than cure. And we'll keep the questions till then. So, Prof. Suhail.
Thank you, Dr. Nuran. Thank you, Professor Sharal. Our last speaker for today, very close friends, Professor Hani Sabur. Prof. Hani is going to speak about comprehensive cardiac evaluation in stroke patients. Dr. Sabur has more than 29 years of clinical experience in all aspects of cardiology and extensive academic experience. He did his training at Harvard Medical School, MGH, and he has been always a clinical assistant professor at Brown University in the US. Currently, he's a clinical professor in UAE and working in the private sector. At the same time, Dr. Hani has a huge contribution to the field of research in UAE and in the GCC Middle East, and he performed more than 800 cardiac EP procedure, including different type of EP studies. Welcome, Dr. Hani Sabur.
Thank you very much, Professor Suhail. It's always a pleasure to work with you and the group for the very important aspect of stroke prevention. Are the slides visible? I just want to make sure.
Yes.
Okay. So with your permission, I've taken some liberty with the title, Cardiac Evaluation and Management in the Stroke Patient, Investigate, Anticoagulate, Monitor, or all three. So one of the things we'll start with a little quick case. It's a 51-year-old woman with an episode of unsteady gait and dizziness less than an hour. On admission, the blood pressure is 140/86, heart rate is 68, no deficits. After an urgent MRI, she's investigated, admitted to the ICU. And you see her ECG here is totally unremarkable. There's no real important findings and clearly no arrhythmia. So this is her MRI. Of course, I'm not the expert, but I think we can see there are two areas of infarct in the left cerebellum. The MRA of the head and neck were negative. Transthoracic echo was normal. TEE shows normal results, but her left atrium was at the upper limit of normal, nothing specifically defined. There was also no visible thrombus, normal velocities in the left atrial appendage, which is a usual culprit, a normal aortic arch, and no PFO. And 24-hour telemetry monitoring was negative for arrhythmia. So the patient was discharged on clopidogrel 75 daily and was followed for an additional 14 days with a 14-day continuous mobile cardiac telemetry. Nothing was identified during this period. 5 weeks after her initial stroke, she developed a recurrence of the unsteadiness and dizziness, right-sided headache with nausea and vomiting, now lasting for 2 hours, readmitted to the ICU with an urgent brain MRI. And as you see, there are now further lesions. So the question is, what next? Give her warfarin with an INR of 1.5 to 2.5. Remember, we saw nothing on the ECG. Xarelto 20, dabigatran 110, apixaban 5 BID, or none of the above. I think the correct answer at this point in the evaluation is none of the above. We don't have a specific answer. So just a quick question for the audience. We may not have time to actually do the poll. In a cryptogenic stroke with a negative 48-hour telemetry, what's your next step? Start anticoagulation empirically, a 30-day external monitor, an implantable loop recorder immediately, and no further workup. We will discuss the answers. And the next point is, and this is really the whole purpose of this talk, should patients with ESUS receive empiric DOAC therapy? Yes, DOACs are superior to aspirin, no evidence to support, only if left atrial enlargement is present and depends on the age. And then after a moderate ischemic stroke, if you do have evidence of atrial fibrillation, when do you restart? Is it 24 hours, 3 to 6 days, 2 weeks, or only after repeat imaging? So we'll try to address all these clinically relevant questions in the talk. Now, the word cryptogenic stroke is not new. It's basically a brain infarction that is not attributable to a source of definite cardioembolism, large artery atherosclerosis, or small artery disease in spite of a standard vascular, cardiac, and hematological evaluation. And it's about 30 to 35% of all stroke etiologies. And there's different classifications and criteria. The bottom line is we don't know where it came from, and therefore we don't know what's the best way to prevent or treat the next one. So in these patients, the risk of recurrent stroke is higher at 2 years because, again, we don't have a pathophysiological way of answering the question. This has been going on for a long time. So there are many potential etiologies. An occult PFO or PFO that was not visible on a standard transthoracic echo, aortic arch atheroma, hypercoagulation or antiphospholipid. Of course, the number one is typically hidden atrial fibrillation. So one of the important points to remember is that permanent atrial fibrillation or paroxysmal atrial fibrillation, ischemic stroke, is equally common. The fact that you don't see it today does not reduce the risk of stroke at all. And in fact, the earlier studies showed that the type of AFib, whether it's permanent, i.e. during the admission, or paroxysmal, comes and goes, and length of time, actually has no effect on the stroke rate. Now, this is difficult because 90% of the patients who have AFib are also asymptomatic, about a third are intermittent. Now, once AFib is diagnosed, everything's clear. You have to use the DOACs or the NOACs as they were. So therefore, we have to look a little bit harder to find this atrial fibrillation if it's about a third of the patients. Now, here's another approach that was proposed years ago. Can you do AFib ablation? Let's eliminate the electrical substrate, get rid of it by cryoablation, RF ablation, or what have you, to eliminate the AFib and therefore reduce the risk of stroke. The answer is no. Actually, if the AFib substrate, which caused the AFib in the first place, left atrial enlargement or atrial myopathy, persists long-term, the risk of stroke is not lowered even after successfully asymptomatic pulmonary vein isolation due to the persistence of what's called subclinical AFib post-ablation. The patient doesn't feel it, but the substrate is still there. So the Crystal AFib study was a landmark study. This was 1,200 patients with stroke, and the duration of AFib was not seen. They did not have AFib. At 12 months, 1,700 AFib episodes were detected in 192 patients. That's a 16% detection rate, and this was 32% increase compared to the Crystal AFib study at the time. And the real world, 72% of patients diagnosed with AFib would have been undiagnosed if they were monitored for only 30 days. Now, there's an additional transformation now in the world, which is the technology of AFib wearables. So many of your patients can actually buy this AliveCore device from Amazon. The Apple Watch actually provides continuous monitoring and actually notifies patients with atrial fibrillation. At HRS in 2017, now we're basically almost 9 years from this, they noted that about a fifth of Americans, and now it's much more, are using mobile technologies such as a Apple or a smartwatch or Samsung watch. And therefore, this is another way to diagnose undiagnosed AFib. And this is the Apple Watch study. There are about 6,000 users using the cardiogram application of Apple Watch. And of those patients, there were 139 million heart rate measurements, about 6,000 mobile ECGs, and then it was validated against 12-lead ECG and expert opinion. And here's what it found. It detected AFib with an accuracy of 97%, sensitivity of 98%, and a specificity of 90%. So this algorithm has now been validated by the FDA. It's on every Apple Watch, and many other smartwatches have been licensed to Samsung, Huawei, all of them have it. And it's a very powerful tool to detect in the community. And in fact, one of the insurance companies in the US actually has given the watch in order to detect early onset of AFib and other parameters to its members. It's about 6 million members. So the traditional approach, though, is to use an implantable device like a loop recorder. Now, the important point of the loop recorder is not this part, which is under the skin. It's this part, where it is transmitted continuously, and some human being is continuously monitoring this. And if an AFib alert is triggered, they call the patient within 30 minutes to an hour to come in and resume anticoagulation 24/7, day and night. So it is literally the supervision and transmission, not the acquisition of the data, because if you do this only and the patient comes to your clinic 30 days later, they may have had a stroke in the interim. So the Crystal AF study really showed this triple combination, the implant, the transmission, and the remote center that's monitoring the patients. Here we saw a 6.4% increase in detection of AFib in patients who are asymptomatic, and this is within 6 months. The detection of atrial fibrillation by 12 months goes up by 7-fold, 7%, 7 times, not 7%. And the detection of AFib by 36 months continues to increase. So this really accrues with time, and it's a 30% by the end of 3 years. And this is really important. This is an 8-fold increase in AFib detection in people who never had symptoms and did not have palpitations. So definitely better than standard of care. Why does it matter? Because now 90% of those patients detected in the Crystal study were then prescribed oral anticoagulant early or late. And I think this is the accrual over time. You can't be complacent and say, well, they haven't done it for a year, they haven't done it for 2 years. Within 3 years, a third of patients have atrial fibrillation. So the duration of AFib monitoring is incremental. So this is a short-term study starting from 24 hours up to 4 weeks. So this is basically the amount of AFib detected in patients with a history of stroke. But out of the 4-week window, you need to continue for a much longer period of time to detect this dangerous disease. So this is where, again, the 3-year detection rates are up to 30% compared to 3% control using conventional methods. Now, is this cost effective? I'm not a health economist, but according to the NICE guidelines, which are very cost effective sensitive, this is extremely important and is extremely useful in these patients. And in fact, the cost of a stroke in the UK is about £60,000. The cost of the implantation of Reveal and starting a DOAC at an early stage over the same period of time is $17,000, not to mention the impact on a patient's life and their health. So this patient, again, after her second event, she underwent extensive evaluation, another workup of hypercoagulability. If you remember, the TE was negative. She subsequently is implanted with an implantable cardiac monitor and discharged empirically on clopidogrel and aspirin, which many of you will disagree with. After 2 months of monitoring, short episodes of paroxysmal AFib that was totally asymptomatic, lasting 15 to 90 minutes, were detected. In spite of having rates of 120 beats per minute, she was then started appropriately on a DOAC. So the standard ischemic stroke workup, as you know, are brain imaging, 12-lead ECG, metabolic, lipid and HbA1c, carotid Doppler or any imaging of the CT, angiogram or MRA. And importantly, we have the arrhythmia monitoring, transthoracic echo. So this is the proposed approach, and this is something we used a lot when I was working at Cleveland Clinic Abu Dhabi, which was a joint cardio-neurology working group. So if a patient has a embolic non-lacunar appearing stroke, particularly in a patient who has no AFib, I mean, if they have AFib, this is solved, or a young stroke patient, the patient would undergo an MRI or CT angio. A bubble echo is important, not just a regular echo, to highlight patients with small non-detectable PFO, and a transesophageal echo. So if you come to this point and the TE is abnormal, at this point the question is, do you need to close the PFO or not? If all testing is negative, then a standard 30-day monitor would be recommended. What was modified is then if the 30-day monitor is not positive, Reveal loop recorder is implanted at the time of discharge. So the TE tells you if there's a structural abnormality. If there's no structural abnormality, here then we would go to the loop recorder. And again, the yield is much better when you start early and continue. These devices last for 3 years. So I think the important point is the diagnostic evaluation is important for secondary prevention. Occult AFib is the tip of the iceberg. The initial cardiac monitorings are insufficient to pick up AFib in the first 30 days. It's really like a placebo. There's a 9-fold increase in AFib detection with the implantable cardiac monitors over many years. Prolonged cardiac monitoring is cost effective, and also we have real life data that we need to look at. Now, I think the key point is we have to document the atrial fibrillation. Now, I'll come back to this point of ESUS and the long history of negative studies where it showed that empiric treatment is not correct. So empiric anticoagulation as of today remains unsupported. And of course, the AFib monitoring is what supports the diagnosis. So these are the studies that I'm going to show you some summary of certain long-term literature. So we have the Embrace study, again, showed early detection of AFib within 30 days if the patient had a continuous monitor. The Crystal AFib, again, showed the progressive divergence, which we showed. And the 3 major studies that looked at empiric therapy, so Navigate ESUS and Respect ESUS, were rivaroxaban and dabigatran respectively. Actually, no difference if you use the DOAC in patients where AFib was not diagnosed. There was no benefit whatsoever. In fact, there was a trend to harm. And again, using the ELAN study, early versus delayed DOAC, again, non-inferior. So you're not helping the patient by empirically putting them on DOACs. This is the more recent study, the NOAA, AFNET-6, and Artesia. Again, no clear stroke reduction and increased bleeding. If you cannot document atrial fibrillation, we are not helping the patient. Artesia, there was a slight non-significant stroke reduction, but there's a bleeding increase. And here the problem was the AFib burden on the detection was not entirely clear. And I think one of the things we get from these devices is it 2 minutes, 6 minutes, 3 minutes. It's clear to me that the presence of atrial fibrillation implies a substrate that is highly thrombogenic, and that's the patient that needs to be anticoagulated, not people who have not proven the presence of AFib. So the empiric ESUS concept is basically a non-lacunar stroke without a major source. It is presumed, or was presumed, that this is occult cardioembolism, and it was expected that DOACs would be superior, leading to the NAVIGATE study with rivaroxaban and the RESPECT trial. These are patients who did not have AFib. So the NAVIGATE study was rivaroxaban versus aspirin, no stroke reduction, terminated early, increased major bleeding. RESPECT study, dabigatran versus aspirin, no overall benefit. There was a small subgroup of elderly who benefited, but again, no proof of AFib, no benefit from DOAC. So I think this is the point why these studies have failed. There is neutrality. The Arcadia study also looked at a different endpoint. They've had patients with atrial cardiomyopathy, with dilated left atrium, and evidence of diastolic abnormalities. Again, this was not positive. So why did these studies fail? Even though 30% of these patients probably had AFib, they were not selected for AFib, and the majority did not. So you're not really getting the benefit of stroke prevention AFib. So there was very low levels of AFib detection prior to enrollment. There are other non-cardiometabolic causes, and here you also have anticoagulation. Why? Without a defined target. Arcadia study tried to look at a little bit more granularity. They looked at patients with elevated biomarkers. So atrial disease based on echo characteristics and atrial characteristics were also included biomarkers, including troponin. Apixaban versus aspirin, no reduction of recurrent stroke. And again, this challenges this whole idea of atrial cardiopathy without atrial fibrillation. You have to have the arrhythmia for this to work. So the critical question is, are we detecting causal AFib? What is the AFib burden that warrants anticoagulation? And is subclinical AFib a mediator or a marker? So these are sort of the studies in summary and table form. Just suffice to say that the hazard ratio only study that has a positive hazard ratio is this one. This is the crystal AFib using the loop recorder to detect AFib and subsequently drive anticoagulation. All the others, which were empiric, are negative. So one of the things we know from the loop recorder literature and also from pacemakers, patients who had an implanted pacemaker, is that the longer you monitor in years, the more likely the patient will have episodes of AFib. The second thing is when you have atrial fibrillation, there is a reason why they have AFib. The atrium is becoming remodeled for whatever reason, whether it's valvular, hypertension, cardiometabolic, inflammatory. And then generally it starts paroxysmal, asymptomatic, persistent, which may or may not be symptomatic, and then finally becomes permanent. So one of the things we're doing now, as was mentioned by the previous speaker, is to try and modify the substrate. Weight loss, GLP-1 receptor agonists, management of diabetes, medications that lower the cholesterol and LDL also have an impact on atrial myopathy, and heart failure with preserved ejection fraction management is the key. So this is from the ESC. Again, opportunistic screening by pulse taking or ECG. In patients with TIA or ischemic stroke, screening for AFib. In patients with pacemakers and ICDs, remote transmission for atrial high rate episodes, which is the surrogate for atrial fibrillation. In stroke patients, additional ECG monitoring with long-term implanted loop recorders to document silent AFib. And this is also very important. So a little bit about the most successful strategy, which is actually the loop recorder. Again, this is after a negative TE. The TE has to be negative before we go for that. It's 3 years. This tiny thing has a 3-year battery. It is completely non-invasive, minimally invasive. I literally have a little device which injects it like this under the skin. It pushes it under the skin under local anesthesia. But the two most important elements are these two. This is now a mobile-enabled device. It connects to the cell phone or to this base unit, and it's continuously transmitting all of this very rich data all the time to the center. So I have a couple of technicians and nurses that are continuously monitoring this. If there's an alert, it goes back to the patient, mobile alert, automatic from the system, which is designed by the manufacturer, and also by phone from us. So this is the portion that's protecting the patient. This is simply a transmitting device, but having it not connected is useless. That is not the benefit of this device. This is how we do it. It's literally injected under the skin. It's a 2-minute procedure in the outpatient or in the cath lab. But again, it's also very important to have a person on this side to notify as well as the patient. So if you have the modern pathway for ischemic stroke where you feel it is embolic, the standard workup should include AFib, anticoagulate, done. No AFib, MRA or CTA of the intracranial vessels, transesophageal echo. Carotid stenosis, obviously carotid endarterectomy or stenting. Intracranial stenosis, again, you have the pathway there, maybe medical therapy if there's diffuse disease. Positive TE with an existing thrombus in the left atrium or left ventricle, anticoagulation. All testing negative, refer for loop recorder. And I think the best practice is to do it in the hospital before the time of admission. Now, if a patient has a pacemaker, they don't need a loop recorder. You don't have to do both. In a patient with out-known AFib and has an implantable device for whatever reason, so sick sinus syndrome, an ICD for cardiomyopathy, these are patients more likely to have AFib anyway. So more than 5 minutes, 180 beats per minute, generally, if they have an elevated CHA2DS2-VASc score, and obviously if this patient has had a stroke, it's very clear this is a patient who will benefit from oral anticoagulation with DOAC. So this is the general pathway, which should be template driven, and also it's a cardio neurology MDT. We work together in these important and clinical scenarios to have a system and have a process. So ECG and 24-hour telemetry at the time of the event. Embolic pattern and no AFib, again, 30-day monitor. If you have a stroke center and the TE is negative, again, you're going to be using a loop recorder at the time of discharge. And if a PFO is detected, you have to have a multidisciplinary approach, including a hematologist, cardiologist, and neurologist. 24-hour telemetry is required in all ischemic strokes. Prolonged monitoring increases AFib detection. Do not anticoagulate ESUS without AFib documentation. The history of the atrium and the imaging studies is not sufficient for DOACs. PFO closure in selected patients less than 60. And if the patient is having atrial fibrillation, DOAC initiation is supported by clinical trials. And with that, I thank you very much, and hopefully there's some time for questions.
Thank you, Dr. Hani. Very nice presentation. Thanks again for all the speakers. Let us now open the floor for question. I would like to invite our speaker to turn on their cameras and to join us for the Q&A. Dr. Nuran, you can start with the first question.
Okay, so I think the first question will be to our speaker, Dr. Aaron. So, Dr. Aaron, there is a question, and I believe that you've answered this question, but if we can let the audience hear it. For a patient with a stroke and no determinable cause, most in practice have hypercoagulable state. Can a D-dimer be used to stratify those who may benefit from anticoagulation? What do you think about that?
Thank you for that question. So I don't think you reflexively anticoagulate if the D-dimer is elevated. However, we do use D-dimer to stratify patients who ought to or ought to not get a CT chest, abdomen, pelvis to look for an underlying malignancy, which would prompt us potentially to anticoagulate the patient. So we say if the D-dimer is about 4 to 5 times the upper limit of normal, then we'll pan scan the patient, potentially get Dopplers as well to make sure there's no DVT or malignancy. I would just caution everyone, if you're giving a patient TPA or TNK, the D-dimer is unreliable if it's drawn after the TPA or TNK. So I would not use that as a marker if you're giving the patient thrombolytics.
Yeah, so it's mainly used just as a screening tool, you mean, right? So it's not something that we will depend on to anticoagulate. Okay,
Correct.
sure, perfect.
Dr. Hani, there's a question about the EF below 20%. is that has any role in anticoagulation to prevent stroke in these patients? Patients came with a stroke, looks like a cardioembolic stroke. There's no atrial fibrillation. ECG or Holter monitor for 3 days was negative, 7 days negative, but his EF is 20%.
Okay. So this is a complex question which actually does have an answer. If you look at the left ventricle ejection fraction, independently, it does increase the likelihood of atrial fibrillation, right? This is common. But the point is, they can also have another source, which is left ventricular apical thrombus or LV aneurysm. Here, the echo has to be very detailed. In fact, in these cases, we use what we call echo contrast. It's something called optison. It actually highlights the left ventricle. And sometimes you can see small thrombi at the apex, which you cannot see on the normal transthoracic echo, especially in obese patients. Now, if you see a left ventricular thrombus, it's exactly the same as a left atrial appendage thrombus, right? This is where the TE and a well-done echo are a must. Here, you're going to anticoagulate because this is arterial thrombosis. And the commonest reason for that is because the left ventricle is dilated, there is stagnation, and often there is an LV apical aneurysm. Patients with hypertrophic cardiomyopathy are particularly prone to this particularly dangerous form of thrombosis. It forms an apical aneurysm because of the increased stress on the myocardium. Again, regardless of the CHA2DS2-VASc score, these patients are anticoagulated. But if they don't have that, then the rule will still apply. You still have to find AFib in these patients.
Dr. Aaron, is that the same answer from your end as a cryptogenic stroke?
Yeah, I think it's a little bit unclear from like a stroke perspective. I would say for a lot of us here, if the patient has a stroke, there's an EF of 20% and we don't see LV thrombus, we will still anticoagulate. But that has not definitively been proven as the right approach. I think we do that empirically, though.
Interesting. I need advice from the
So on the echo, if you have, so there's a phenomenon, I mean, this is a little bit getting into the weeds here, but there is a phenomenon called swirling. So you can see on a good, well-done echo, you can see this rouleau formation or stasis. Again, this is sort of a joint cardio neurology decision, right? If you see visible pre-thrombus, which is sort of dense, what you see in the left atrial appendage, some of us will definitely do that when they do a left atrial appendage TE. If it's dense and it looks like it's almost organized like sludge, many of us will default to this. But this, again, is more empiric rather than, as Dr. Aaron mentioned. I mean, this is a decision. We sit down together, we review the case, and we make a choice if it's a risk-benefit analysis.
The last question from my end as time is running. Dr. Aaron and Hani, we have two young neurologists, stroke specialists with us. I believe both of you read the article by Matt Schumer mentioning and speaking about the AI and the new innovation and the changes which is happening over the last 12 months. Where do you think the future of stroke management, screening, primary, secondary prevention is going there? Aaron? Hani?
So Mayo Clinic has actually developed a remarkable artificial intelligence that can detect the possibility of AFib in sinus rhythm. This is like crazy. I'm not even understanding how that's possible. But over reviewing millions and millions of ECG, this AI is able to detect small changes in the atrium, small changes in the ventricle that we cannot see in the naked eye. And it's actually able to detect prospectively the development of AFib. I don't know if that's ever going to be, a way for us to determine that the patient needs to be anticoagulated. But I think there's so much data now that's coming, it's mind-boggling. I don't really know how we can process it. But yes, there is from your sinus rhythm ECG, you can say the patient probably has atrial fibrillation.
Aaron, anything?
Yeah, I think the future is very bright with AI. It's very exciting technology. I think it's going to be a multi-front kind of change within stroke. I think we're going to see more kind of automated reads with AI of, identifying large vessel occlusions and subtle hemorrhages and things like that. I think there are going to be a lot more kind of risk scores that are created by big data that AI and large language models use and can create of their own volition. And I think a lot of things are going to change in terms of diagnostics and treatment. because we'll just much more quickly be able to do the kind of research and analyses that we weren't able to do as fast before. So I think the future is very bright with AI.
Thank you. Nura.
Yeah, so there is one question here for Dr. Salama is about the published complication in the literature about the use of either IV thrombolysis or EVT on the fetus, and what is the most common to happen for the fetus in such case?
Okay, so again, because the data that are published are very limited, especially on the use of thrombolysis when it comes to pregnancy. But I think what we need to highlight is the main two complications that we worry the most about. One is teratogenicity, which we should be more reassured about because both IV thrombolytic agents are very large molecules, so they are less likely to cross the placenta. Now, the other one would be the miscarriages. Now, some studies have suggested that there could be a risk of miscarriage. However, there is no clear clarity when these miscarriages happen. What was the maternal status, especially the hemodynamic status of the mothers during these miscarriages? How severe was the initial stroke, and was it a contributing factor to that as well? So there is a lot of unanswered question in that itself. I think maybe more studies, more data is required to finalize these answers.
Yeah, thank you, Dr. Salama. Totally agree. One question for Dr. Muhannad. So it was about your case. Do you think that the recurrent stroke in your case is related to the use of anticoagulation or related to the mass itself?
Yes, interesting. Actually, the course of this patient, while she was on anticoagulation, no more strokes. So first 2 days, patient who wasn't on anticoagulation, so her heart created more thrombi and she got another stroke. And third one were contributed most probably to hold anticoagulation for 2 days. So I think I know there is like proximal effect of vitamin K sometimes give a contralateral effect. However, in this case, patient on anticoagulation, she is no more stroke, no anticoagulation, she developed stroke. So the question were easy in this case.
Okay, thank you. There was a question for Prof. Cheryl, but unfortunately she had to leave. And it was a very interesting question about, do you think that we should open a dedicated clinic for a primary stroke prevention? And she mentioned that yes, and to call it as a brain health clinic. But what do you think, Prof. Suhail? Who should be responsible for that? Neurologist or stroke neurologist or the primary healthcare physician? I think that's quite interesting approach, and I believe it will be the approach in the near future. But how do you see it?
I believe that this area of primary prevention, all the subspecialty should be part of this one, but I think the primary healthcare and GP should work on that, maybe using the stroke specialist, the cardiologist, the internal medicine as advocate for these type of clinic. But everywhere in city of Dubai, we have GP and PHC centers there. These people should screen the patients for primary prevention. These patients should advocate losing weight, early intervention for high blood pressure, but that's under the umbrella with the cardiologist and the stroke specialist and neurologist.
If I may add a small comment. So there is an ongoing project between the Emirates Cardiac Society, Emirates Diabetes Society, and Family Medicine. It's called the UAE Cardiometabolic Process. So we can explain that to cardiovascular as well. That's the key point. At primary care level, intensive control of risk factors, hypertension, dyslipidemia, diabetes, renal disease prevents complications, including stroke. This is obviously the best investment because they see the vast number of patients before an event. It's education driven as well.
Totally agree. Shall we conclude our meeting, Prof. Suhail?
I think, yes. Sorry about making everyone late for 13 minutes. At the end, I would like to thank all our 5 speakers. It was so nice to speak about stroke prevention. Please, you will get your CME 2 hours within 2 weeks. And I would like to remind all of you about our annual Congress, which will be for the first time in Kuwait City between the 8th and 9th of October 2026. I encourage who's interested in stroke to see us and to meet all the experts of stroke in the Middle East in that city. Again, I would like to thank Dr. Aaron, Cheryl, Dr. Hani Sabur, Muhammad, and Salama. Thanks, my friend.